call our meeting to order and continue our briefing on the opioid summit that just took place. And we're certainly pleased to have the Honourable Jane Philpott, the Minister of Health, with us today. I understand she's here for an hour, and she has some other duties she has to perform, so we should get right into it. Also from the Department of Health, we have Simon Kennedy, Deputy Minister, and Hilary Geller, Assistant Deputy Minister. And also from Public Health Agency, we have Dr. Gregory Taylor, Chief Public Health Officer, back for another little visit. But I want to thank you all for coming, and we have an opening statement of 10 minutes. If you'd like to make a statement.
Yes, I would be happy to make a statement. Thank you, Mr. Chair, and the members of the committee for the opportunity to come and be with you today to speak particularly to the opioid crisis, which I gather was one of the reasons why you wanted me to appear before you today. And thank you, Chair, for introducing my colleagues from Health Canada and Public Health Agency of Canada who are with me today. So I do have a few opening remarks, and then of course I look forward to your questions. But before I start, I want to thank this committee for the fantastic work you've been doing on a whole number of fronts, and let you know how much I appreciate the work that's being done here and how I look forward to further studies that come out of this committee. In particular, I want to thank you for your study and report related to the opioid crisis. As you know, this is a serious matter facing our country, and of course we have differing views on certain strategies, but we know that overall this is an issue that needs to be addressed from a public health perspective. It's not an issue where partisanship needs to interfere, but we need to focus on saving the lives of Canadians. I think this committee is well aware of the statistics, the fact that hundreds of Canadians have died already this year. If you look at British Columbia alone, the numbers up to the end of October were over 600 deaths related to opioid overdoses. And I'm sure that the committee also heard a great deal about addiction as you were doing your study, and you heard people talk about the fact that addiction can happen to anyone, that in fact it's a chronic illness, that it affects people of all ages and of all socioeconomic groups, and it impacts communities all across this country. These matters are urgent. The number of deaths related to opioids has complex roots, it's multidimensional, and it requires swift action on behalf of all of us here in this vocation. I have been addressing this matter actually since the very beginning of my responsibilities as Minister of Health, and taking decisions which have been taken in an attempt to promote health and to save lives. And I believe that we need to continue to have a health-focused approach to the opioid crisis. Some of you know that last month I was in British Columbia and visited frontline workers, was at Fire Hall 2 in downtown Vancouver, and met with paramedics and police officers and firefighters there, as well as many healthcare providers, and hearing from them about what this means on the ground and the challenges that they face every day trying to save the lives of victims was very moving for me. Then later that month, I, along with the Ontario Minister of Health, Mr. Hoskins, hosted a large gathering. Some of you were able to attend a conference and then a summit where we had representatives of government, we had healthcare professionals, community members talking together about how we need to respond. We have taken many government actions to date on this, including, of course, the work of this committee. And we have continued to focus on a public health approach. You have no doubt heard of some of the announcements yesterday, which I'll refer to shortly. But first of all, I wanted to make sure that you're aware of the number of steps that have been taken so far. One of the early steps that we took was to make sure that naloxone was available on non-prescription status. We also heard about the need for naloxone nasal spray, and we were able to expedite an emergency importation mechanism to get nasal spray into the country. We were later able to expedite an approval of naloxone nasal spray for production in Canada. We realized that one of the things we needed to do was to focus on harm reduction, and in that light, early on, I approved an exemption for the Dr. Peter AIDS Centre to operate a supervised consumption site in Vancouver. We were also able to give an unprecedented 4-year renewal to Insight, which is an extraordinary site based in downtown Vancouver. We also were asked to reverse the federal prohibition on the use of diacetylmorphine, which is pharmaceutical heroin, which is proven as a medication for the treatment of addiction, and that is now available under a special access program. Last week, we took steps to schedule fentanyl precursors, making it harder to access some of the chemicals that are used to make illicit fentanyl, and, as I said yesterday, introduced amendments to the Controlled Drugs and Substances Act and other acts. It's important to recognize the big picture of why we did that. It is fundamentally taking a health-based approach to problematic substance use, and the new Canadian Drugs and Substances Strategy replaces the former National Anti-Drug Strategy. It formalizes the government's approach to drug policy, which is comprehensive, collaborative, compassionate, and evidence-based. The lead for the strategy has now returned to the Minister of Health, and we have reinstated harm reduction as one of the 4 pillars of drug policy, along with the pillars of prevention, treatment, and law enforcement. If you can ask me more details later, but I wanted just to give you a bit of an overview of what's included in some of the details of that bill. One of the things that we did was to streamline the approach for communities who feel that there is a need to have a supervised consumption site in their community. And in order to do that, we removed the 26 criteria that had been in place in the previous legislation, and we replaced those with a requirement for the Minister of Health to demonstrate evidence of public health and public safety benefits. This comes in part from the 2011 Supreme Court decision, which stated that where the evidence indicates that a supervised injection site will decrease the risk of death and disease, and there's little or no evidence that it will have a negative impact on public safety, that the minister has a responsibility generally to grant an exemption. The Supreme Court also gave us guidance on what kinds of things the Minister of Health should take into consideration in making that decision, and there were 5 factors in particular that were emphasized. One is that, of course, there has to be demonstration of community need. Second, there has to be a demonstration of community consultation and support. Third, the minister has to have an understanding of the potential impact on crime rates. Fourth, there need to be regulatory systems in place. And fifth, there needs to be evidence that the site has the appropriate resources in place. Given all this, we know that there is an abundance of evidence that well-established and well-maintained supervised consumption sites in communities that want and need them will save lives, prevent infection, introduce people into the healthcare system in a way that will not increase crime rates and will not increase problematic drug use. So there are a number of other elements in the bill which you may want to ask about. You have probably heard that we will be prohibiting unregistered importation of pill presses and encapsulators to help to address the matter of illicit supply, production and distribution of drugs. We will be removing the exception in the Customs Act that currently prevents border officers from inspecting mail that's 30 grams or less, and this will allow us to stop the importation of dangerous substances such as fentanyl, which is often shipped in these very small packets. And there are a number of other amendments to the Controlled Drugs and Substances Act. They're there to help increase the flexibility that we have to address emerging risks. They allow us, for instance, to temporarily add a substance that we believe poses significant risk to public health to a temporary schedule on the Controlled Drugs and Substances Act, pending a comprehensive review and a decision on permanent scheduling. So, all in all, the response to the opioid crisis requires a comprehensive approach. It requires actions like those that we took yesterday to essentially stop people from drowning, as it were. But we also, of course, have to take steps to address root causes, the reasons why people fall into the water in the first place, if we were to use that water metaphor. And the Canadian Association for Mental Health talks about the opioid crisis having multiple roots, and some of those roots are in the healthcare system itself. Canada is the second highest per capita consumer of opioids, and so we took steps during the summit to address the roots of the crisis in terms of the role of prescription drugs. We brought together at that meeting 7 provincial and territorial health ministers and a broad range of stakeholders and developed a very interesting and impressive list of actions that these 42 organizations are committed to taking in a joint statement of action, and there's a commitment on our part to report on the progress quarterly. So all in all, I thank you for being here today. Thank you for working alongside to be able to address this very serious matter that affects some of the most vulnerable Canadians. We need swift action on this. We need a renewed focus on the public health approach that includes harm reduction, that addresses root causes. We absolutely have to work collaboratively to save the lives of Canadians and promote their health. Thank you very much.
Thank you very much, and you're right on target. 10 minutes. So we're going to go to questions now. We'll go to our first round of 7 questions. We're going to start with Mr. Ayo.
Merci, Monsieur le.
Thank you, Mr. Chair. Thank you, Madam Minister, for coming to speak to us today and for your considerable contribution to addressing the crisis that you identified. And yesterday's announcement is a positive one and is turned towards the future. I'd like to focus on, well, there are 5 criteria established for opening safe injection sites. There are only 2 safe injection sites in Canada currently. How many sites are being considered, and how many should we adopt? Do we have an exact objective on that? We've heard discussions with the provinces and communities that are affected. Is there an objective, and if so, what is it?
Actually raised a whole series of questions within that, and I'll try to speak to each of them if I can. I encourage members, if you haven't, to read the Supreme Court decision of 2011, which was informative for us in coming up with this legislation yesterday, and does lay out the criteria as to when and if these kinds of sites should be approved. I think you'll see that's quite helpful. You spoke to the matter of the number of sites that there are, and you're absolutely right. There are 2 who have so far received an exemption, the Dr. Peter AIDS Centre and Insight, both of those in Vancouver. There are a number of applications that are in place. I believe there are 3 from Montreal, if I'm not mistaken. 4 now from Montreal, 2 from Vancouver, 3 from Toronto, and is that it? Okay, so those are all of the ones that we have received the full entire application. There are several other communities who have applications that are in process, and my department has been helping them in some of the steps along the way. One of the challenges under the current legislation was that we were not able to comment or even provide feedback or begin a review of an application until it was complete. And that requires, in some cases, as in some of the new applications in Vancouver, that they have an almost complete application. They have some work to do on, for example, renovating the space where they want the site to be available, but we can't actually do all of the work until things are complete. So our commitment now is to have a much different approach in a number of ways. One is that we intend to be able to post online the progress that sites are making so that they can see where they are and which pieces are missing. The federal government actually takes the heat on not approving these sites when many times the barriers to site approval have nothing to do with the federal jurisdiction. It has to do with local municipalities. It has to do with provincial governments providing support, for example. So we want to be more clear in that so that advocates who are pushing on the right levers to be able to get these sites open. We're also committed to allowing partial reviews of applications that are in process once this legislation passes through. Hillary may have some other things to add, but I just wanted to also, your last question I think was really important in terms of where do we foresee these going in terms of, how many communities will have them. And I think it's very important, this committee will have an essential role in this, to not cause undue anxiety in communities where it's absolutely not appropriate to have supervised consumption sites. This is a crisis that is spotty in where it affects people. Yes, there are people who die of overdose deaths across the country, but there are some areas where the crisis is intense, as in southern British Columbia. In those communities that want and need them, where there's strong community support, we have to be able to make them available to save people's lives. But there are all kinds of communities in the country where it's not appropriate, where there's no community desire to have one, there's no demonstrated need, and clearly, you know, the fear-mongering around supervised consumption sites on every street corner is not helpful at all, and we need to make sure that these will go to the communities that need them, that are crying out for them because people are dying, and we need to support those places. But I don't know, do you want to fill in any blanks there? Okay.
Okay, merci. Merci pour la...
Thank you. Thank you for the very clear answer. In the approval criteria for new sites, they were reduced to 5. So normally we want to simplify the process, make it faster in terms of approvals for places where they need it most, as you explained. We're now hearing that there are people who are for and against. It's never really 100% cut and dried. In one of the criteria is the recommendation of a police service. And there is the Supreme Court decision that you mentioned that clearly shows that there is a drop in crime when sites are established, in addition to a drop in sudden deaths among addicts. What types of measures will you take to inform or raise the awareness of police services, which seem to be more resistant? Some of them. The Ottawa Police was not yet certain of the approach, for example, where there are other places in the country where they are very open to the idea, and they are waiting for this approval with anticipation. What does the Department of Health want to do to help these people? Is there a particular approach that you're taking?
And it gives me an opportunity to clarify that there will still be an application process involved that speaks to how the minister will get information to be able to make sure that those 5 factors have been appropriately considered. And so things like demonstration about whether there's an impact on crime, for instance, there will be guidance within the application process to be able to show how that could be demonstrated. And some of it could be by, for example, having correspondence related to the chief of police in that particular area. So there will be ways that we will support communities to be able to demonstrate that they have met the specific factors given by the Supreme Court. The point that you raise is a very interesting one in terms of sometimes hesitation on behalf of law enforcement as to whether or not this is a helpful mechanism. And I would encourage members, if you ever possibly can and you're in Vancouver, to go visit some of these long-standing supervised consumption sites like Insight. It's been established since 2003. You cannot help but be moved by this place. Where people are greeted at the door in a non-judgmental way, where they make every effort to reduce the stigma associated with problematic substance use, where people are welcomed in, given opportunity to be introduced to the healthcare system at the point that they are ready. Anyway, I could go on and on about how impressed I was by the work of Insight and how I really see it as being a helpful resource in that community. The interesting thing that happened in Vancouver is that there was, you're right, there was not 100% community support at the time that it was originally approved, but all evidence says that many people who were initially skeptical about whether or not this would be helpful in terms of decreasing crime rates, decreasing, for instance, the number of dirty needles that were in local parks, etc. People have come around, and the community support and the support from law enforcement, in particular Vancouver Police, is absolutely stunning. People are convinced that this has been an effective mechanism, that there have been 0 deaths, despite the fact that there are literally hundreds of people that use these services every day. And I think for law enforcement officials in other communities that are skeptical, I would certainly encourage them to go and see what an effective site can look like.
Thank you very much.
Time's up. Okay, now welcome to our committee. Mr. Brown, you're up.
Thank you very much, Mr. Chairman, and thank you to our officials and the Minister for coming today. And I think it's a positive development that they're here on the opioid study. It's actually a very terrible thing that's happening in our country, so thank you for coming and the government making this a priority and addressing this. However, Minister, as you know, I've asked you 3 times in the House about thalidomide, and we have a motion on notice, which was on December 9th by Rachel Harder, and I'm subbing in for her today. And that motion is that, pursuant to Standing Order 1082, that the committee immediately undertake a study on thalidomide that A, focuses on the forgotten survivors of thalidomide, and B, examines the effectiveness of the 2015 Thalidomide Survivors Contribution Program. And so, Mr. Chairman, that motion is in order, and I'm now going to speak to that. I'm happy to speak to this motion that is essentially asking the committee to examine the effectiveness of the Thalidomide Survivors Program. I believe from the evidence that I've seen that the committee at the end of the study will be calling for a fair treatment of and compensation for the forgotten thalidomide survivors who cannot produce paperwork or witnesses to prove that their mothers took thalidomide. I believe that with a study that the committee will find that these people need to be given a personal interview by a qualified professional and then given whatever tests are required to prove that their physical disabilities are not caused by a genetic anomaly. I'm aware that there is no test that can prove thalidomide use by their mothers, but that the physical evidence that they all display and genetic testing to prove that it isn't something else can go a long way to drawing the conclusion that thalidomide is the cause of their disabilities. I believe that with a study, this committee will recommend that Crawford Victim Services, the company making the decisions about whether or not to compensate these survivors, should be trying to include people in the compensation package, not exclude them, which I believe from the evidence I have seen is their current practice. On several occasions in the House, I've asked the Minister of Health to address this situation, and she has been asked the same question by the media. She continues to refuse to act compassionately for these survivors, so I'm asking that this committee to use its independence to undertake a study to determine what can be done to help these folks. On October the 25th, a number of the forgotten survivors were here in Ottawa as my guests to address the media about the unfairness of the current compensation process. I want to quote extensively from remarks that were given by Mr. Terry Bolton, who is here in the committee room today. But before I do that, I want to note that Mr. Bolton lives in my community of Gananoque, Ontario, and I've known him since we were both young children. To see Mr. Bolton, if you know anything at all about thalidomide, you can clearly see he is a victim or survivor of the drug. That is the first thought that crosses your mind when viewing his physical condition. He has phocomelia, from the Greek word folk, meaning seal, and melos, meaning limb, in which the hands or feet or both start immediately from a main joint like the flippers of a seal. This is the limb malformation most traditionally associated with thalidomide. He also has an extra thumb that was amputated at birth, another dead giveaway marker of thalidomide. So allow me to tell his story in his own words. He said, in 2012, I found out that my mom had taken the morning sickness drug thalidomide while pregnant with me in 1962. I confirmed this with her 2 surviving sisters. Up until then, I had been led to believe that I was a gift from God and made special. I set about to educate myself on everything related to thalidomide. Upon doing research, I discovered that my deformities and internal organ problems were side effects caused by thalidomide. I had numerous operations as a child. My intestines were bleeding from somewhere, but they never really determined where exactly, but proceeded to remove my appendix as well as my Meckel's diverticulum. My internal ear organ on the left side is missing parts, resulting in tone deafness since birth. I'm now considered legally deaf in both ears. I was also born with a left deformed arm and hand and with an extra thumb on my right hand. This was surgically removed at birth. I was also born with very deformed toes on both feet, which resulted in surgery to remove a double bone in one of my toes. I also had heart surgery to correct what is referred to as Wolff-Parkinson's-White syndrome. Basically, my heart had an extra valve that was causing it to do more work than needed. This was believed to be the contributing factor in the 40% mortality rate of thalidomide babies. I got lucky and lived with my murmur for 49 years. I tried diligently to obtain my birth records and medical records as requested by Crawford. I remember my orthopedic surgeon, Dr. John Hazlitt, telling me as a child of 8 or 9 that we have enough x-rays of you to make 6 complete skeletons. Well, according to my birth hospital, all records and x-rays have been destroyed due to their retention policy. I researched to find out there was a fire in their records building between 75 and 79. There were also 2 fires in my hometown of Gananoque that destroyed the pharmacy that my parents used, as well as my family doctor's office. I believe every one of the forgotten survivors, as well as the other survivors, have similar stories to tell. This now comes down to why we are here, and he said that on October the 25th. We, Canada's forgotten thalidomide survivors, wish to be recognized and compensated for the tragic mistake that the Canadian government made in 1959 when they allowed thalidomide into our country. It is time to right a very big wrong. That is the end of his remarks. Now, living in Gananoque, I can verify personally that the fires that he mentioned in his presentation occurred as he stated. I do remember both of those fires that happened when I was a teenager. I talked with each and every one of those victims who came here to Ottawa, who were here on October the 25th, and their stories are truly heartbreaking. They have all suffered all of their lives because of their exposure to thalidomide, and now they are being denied even the decency of an in-person interview to see if they have the effects of thalidomide. They've all had extreme health issues, medical issues that continue to this day. These issues have required hospital stays and operations. Many suffered from abuse and cruelty from other kids. Many, like Mr. Bolton, have taken as much training as possible but have been unable to work or even find employment. One woman featured on a recent W5 report about the forgotten survivors who has survived a lifetime of rejection lives alone in the backwoods of British Columbia. As I said, their stories are heartbreaking. The thing that really bothers me...
Mr. Brown, your time is up.
I'm sorry that I have unlimited time on this motion.
You're moving a motion?
I moved the motion, and I...
okay, I just want to clarify.
I'm sorry, I'm going to continue. This motion is in order.
Yeah.
As I said, their stories are heartbreaking. The thing that really bothers me about this is that we are talking about a couple of dozen people.
I want to thank the member for his very impassioned statement and the motion he's bringing forward, but we do have the Minister of Health here to discuss the opioid crisis. We stopped our other work to deal with this crisis, so I would move that we suspend further debate on this topic and return to our discussion of the opioid crisis.
Okay. Mr. Chairman, my motion is in order, and I am speaking. That's not a point of order.
He's right.
The thing that bothers me about this is that we are talking about a couple of dozen people. In the overall scheme of things, what financial impact will assisting them have on our country? Let's put this into perspective, the cost in order to make their lives a little bit easier for however long that they have remaining. As I said in the House, it is a disgrace to think that we as members of Parliament in the greatest country in the world can't collectively do something to assist a few of our fellow citizens who have suffered since birth as a result of a decision that was made by their country's federal health department. Canada offered a compensation package in 1991, and it included an in-person examination. Many people, such as Mr. Bolton, were either not aware of the 1991 package, or as in his case, their mothers were never admitted to them that thalidomide was the problem. It was only after his mother passed away that he learned the truth from his aunts. It is important to note that Canada is not alone in its compensation offerings. Countries such as Britain, Germany, where the drug originated, and Australia have also offered compensation package to their victims. In Britain, there was one offering, and then there was a second greater offering after the victims realized that the first package wasn't enough to compensate them. Victims received the courtesy of an in-person examination. For those who maybe don't understand thalidomide, let me use information from a website that was organized to provide such background to Canadians. This will explain the history and background to this issue. Thalidomide was first marketed commercially in West Germany in 1954 by the drug company Chemie Grummenthal. There is some unproven evidence that may have been developed during the Second World War by Nazi scientists. This stems from the fact that a known Nazi was hired by the drug company shortly before the release of thalidomide. It was available to patients in West Germany into the 1960s. Thalidomide was present in at least 46 countries under many different brand names. Thalidomide became available in simple tablet form in Canada in late 1959, and it was given to many pregnant Canadian women to relieve morning sickness and to help them sleep. Some of the forgotten survivors today were the result of the samples that were given to their mothers. This means that they could not come up with a prescription order even if the pharmacy record still existed. There is unconfirmed evidence that it may have been brought into Canada even earlier than this by doctors who had served in Korea and had come across the drug. It was licensed for prescription use in Canada on April 1, 1961. Although thalidomide was withdrawn from West Germany and United Kingdom markets by December 2, 1961, it remained legally available in Canada until March 2, 1962, a full 3 months later. Incredulously, thalidomide was still available in some Canadian pharmacies until mid-May of 1962, and sample packs may have been given beyond this date. Thalidomide was hailed as a wonder drug that provided a safe, sound sleep. Thalidomide was a sedative that was found to be effective when given to pregnant women to combat many of the symptoms associated with morning sickness. It was not realized that thalidomide molecules could cross the placental wall, affecting the fetus until it was too late. Thalidomide was a catastrophic drug with tragic side effects, and not only did a percentage of the population experience the effects of peripheral neuritis, a devastating and sometimes irreversible side effect, but thalidomide became notorious as the killer and disabler of thousands of babies. When thalidomide was taken during pregnancy, particularly during a specific window of time in the first trimester, it caused startling birth malformations and death to babies. Any part of the fetus that was in development at the time of ingestion could be affected. For those babies who survived, birth defects included deafness, blindness, disfigurement, cleft palate, many other internal disabilities, and of course, the disabilities most associated with thalidomide, phocomelia, as Mr. Bolton displays. The numbers vary from source to source, as no proper census was ever taken, but it has been claimed that there were between 10 and 20,000 babies worldwide born disabled as a consequence of the drug thalidomide. There are approximately 5,000 survivors alive today around the world. Never counted and never to be known are the numbers of babies miscarried or stillborn. Also never counted were the number of family members and parents who have suffered over the years as they struggled with their conscience and the care of their affected children. Around the world in the late 1960s and into the early 70s, the victims of the drug thalidomide and their families entered into class action legal suits or threatened actions against the various drug companies who manufactured and or distributed the drug, and they were eventually awarded settlements. In most countries, these settlements included monthly or annual payments based on the level of disability of the individual. In Canada, the story was different. Canadian victims of the drug were forced to go it alone, family by family. No case ever reached a trial verdict. Rather, families were forced to settle out of court with gag orders imposed on them not to discuss the amounts of their settlements. It is startling to believe, but even today, as compensation is awarded to survivors, they are faced with gag orders on their compensation packages. The earlier gag order settlements resulted in a wide disparity in the compensation amounts, with settlements for individuals with the same levels of disability varying by hundreds of thousands of dollars. In 1987, the War Amputations of Canada established the Thalidomide Task Force to seek compensation for Canadian-born thalidomide survivors from the Government of Canada, as Canada allowed the drug into Canadian markets when many warnings were already available about side effects associated with thalidomide. And as Canada left the drug on the market a full 3 months after the majority of the world had withdrawn the drug, it was felt and argued that the Government of Canada had a moral responsibility to ensure that thalidomide survivors were properly compensated. In 1991, the Ministry of Health, or National Health and Welfare, now Health Canada, through what was called an Extraordinary Assistance Plan, awarded small, compassionate lump sum financial assistance grants to Canadian-born thalidomide survivors. The lump sum payment was offered ex gratia, meaning Ottawa recognized no legal liability in offering the money. The payout amounted to $8.5 million, which worked out to about $52,000 to $82,000 per victim. depending on the degree of disability. These payments were quickly used by those individuals to cover some of the extraordinary costs of their disabilities, and for most survivors, these monies are long gone. Thalidomide survivors are now in their mid-50s and they are experiencing physical deterioration due to stress placed on their different body structures, further limiting their abilities and often resulting in new disabilities as a result of degeneration of joints and limbs. This is compounding the tragedy. The needs and problems of this unique population are many and overwhelming, and that is adding to their day-to-day struggle to adapt and survive. And that is the background that brings us to the government's compensation offer in 2015. It should be noted that as a result of different appeals in Britain, nearly 470,000 thalidomide survivors now receive annual payments of about $88,000 each per year from both the Canadian or British government and the thalidomide drug distributor. In Germany, where the drug was first marketed, the federal government gives its 2,700 survivors pensions that total up to $110,000 a year. Here in Canada, as a result of the 2015 compensation package offer introduced by then Health Minister Rona Ambrose, each thalidomide victim was to receive a lump sum payment of $125,000 and an annual tax-free pension for the rest of their lives of $25,000, $75,000, or $100,000, depending on the severity of their condition. As well, survivors are able to access a special $500,000 medical assistance fund to defray the costs of mobility devices and other adaptive tools they may need. The outstanding issue, of course, is the forgotten survivors, as they prefer to call themselves. They are a small group of people.
Just a second.
I'm almost finished, Mr. Chairman. Probably fewer than 2 dozen from that period.
I just want to explain, the minister has to leave now by prior arrangement. We arranged the timing to
the minister was going to be here till 10 o'clock. I have about 1 minute left, Mr. Chairman.
She has to leave.
These are the people like Mr. Bolton. After months of work trying to prove their case, they were rejected by a form letter sent to their home. As I stated earlier, this is shameful, disgusting, and quite frankly embarrassing to all of us as parliamentarians and to Canada as a caring, compassionate nation. The minister has refused to address the issue with Crawford, so I'm asking the minister who is here to look at this again. I'm also asking the committee to support this motion, use their independence to examine the issue, call these survivors as witnesses, call in the medical experts as witnesses, and decide how we can proceed to assist them. That, I believe, can be accomplished with a simple examination by a qualified professional. Other countries accomplish this. Why can't Canada? These victims have endured a life of pain, suffering, discrimination, and lost opportunity. Let's not make another unhappy and depressing Christmas for these folks. Thank you very much.
Okay, thanks very much. Now we have a motion on the floor. Do we have debate? But Madam Minister, if you need to go, you're free to go because we arranged that. All right. First of all, Mr. Davies.
Yes, Mr. Chairman, I'm going to now proceed to take my 7 minutes to ask the Minister questions on the opioid crisis, the reason for which she's here. So, Minister, first of all, I would like to thank you for once again publicly stating that addiction ought to be treated most properly as a health order, as a health issue.
There's a motion on the floor, is there not, Mr. Chair? And should we be discussing the motion
he
on the
asked
floor?
to speak, so he's chosen to do this, but it is not pertaining to the motion. So would you address the motion? We have to address the motion and do it. Wait, just a second. But are you done?
No, I'm not done, Mr. Speaker.
Okay.
I will address the motion when I get around to the thalidomide issue. But for the moment, I'm going to direct my question. I am not restricted. No, well, Mr. Speaker, I am not restricted to dealing directly with the matter at hand. I'm allowed to raise peripheral issues, and I will eventually come to make a connection between the devastating impact of opioids as a connection with the devastating impact on the thalidomide victims as well. But I would ask that I be given some latitude to do so.
Fire away.
Thank you. And I'd also like to thank the member for restoring harm reduction as a key pillar of this issue. As my honourable colleague just talked about, there's a number of different conditions that affect Canadians, from the devastating impacts of thalidomide to the current problem facing opioid addiction in this country. Now, Minister, As you know, in 2015, the Liberal Party publicly stated that the Conservative C2 was a deliberate barrier to opening safe injection sites, and of course it was, because we know that not a single safe injection site has been opened since that legislation was passed. Many stakeholders have called on your government to repeal C2 for over a year now, and this is not purely of academic concern. In the last year alone, over 2,000 Canadians, as you've pointed out, will die from drug overdoses, mostly from opioids, as people have died from thalidomide. Now, in the last week of Parliament of 2016, really the last week, you've introduced legislation to streamline C2, and I congratulate the government on doing that. But, of course, it being the last week before Parliament adjourns for Christmas, this bill will not be dealt with until February of 2017 and not passed until spring of 2017 at the earliest. That's months from now. Now, the Minister of Health for British Columbia last night said that the opioid crisis in BC is, quote, like a war, end quote, and that they can't wait for this legislation to be passed. I think Dr. Perry Kendall in British Columbia, the public health officer, said the same thing, that they're not waiting, and you've pointed out, I think with some power, the impact in my home province of British Columbia of these opioid deaths, where almost 700 British Columbians will die this year. Pop-up clinics are operating right now in British Columbia to provide emergency services that are either illegal or operating in a legal gray zone. Now, as you know, this committee conducted an emergency study into the opioid crisis, and the very first recommendation that this committee made to your government, all party support, was to declare this a national public health emergency, like the thalidomide issue was. Now, the reason for this is that it would give the Public Health Officer of Canada extraordinary powers to act immediately while your legislation works through the House over the next 3, 4, 5 months, including opening emergency clinics now for safe consumption, for naloxone administration, or for drug testing, whatever these emergency clinics could be used for right now to save lives. So my first question to you is this. Minister, why don't you declare a national public health emergency to give the Public Health Officer of Canada these extraordinary powers in the next 90 days so that we can start saving lives now while your legislation takes time to work through the process?
Yes. Point of order?
It's a bit unusual, but I'm not sure that witnesses are allowed to participate in a debate on a motion.
A good point. Do we have a decision on that?
Meaning me, I can't participate.
I guess.
This is where we need democratic reform.
But if she doesn't want to speak about it, it's up to the option of the witness to comment on the question.
Thank you, Mr. Chair. I would think it unusual that the Minister of Health could not participate in a debate on an issue concerning thalidomide or opioid crisis. But
thank you. So, Mr. Chair, I gather you would like me to respond to the most recent intervention?
Your option.
Okay, thank you. Well, as time is running short in terms of my availability, I think I will speak very briefly to the motion that was mentioned, but I would also like to make comments on what's been brought to me by the first intervener on the motion. And perhaps I'll start there. I was, as members know, invited on the basis of a motion to come and speak to the opioid crisis. So I do want to make sure I comment on what's been most recently said. And you brought up a number of issues, and I think the one that you were asking most directly for was why not declare a national emergency, and I think it's important to speak to that. So the mechanisms available to the federal government on the declaration of an emergency are somewhat different than the powers that are vested in provincial governments for a declaration of an emergency. And British Columbia effectively declared a public health emergency and have found it helpful to provide them with tools that they didn't already have. Under federal legislation, there is currently an Emergencies Act. It is a modernization of the previous War Measures Act The War Measures Act was implemented under 3 occasions, World War I, World War II, and the October crisis. The current Emergencies Act has never actually been implemented, and I have asked my department, including the Public Health Agency of Canada, to investigate whether a declaration of an emergency would be appropriate under the Emergencies Act. In order to do so, we would have to have exhausted all other possible resources, and it would essentially take over powers that are currently vested in provincial governments to be able to act on public health. So the analysis of the department to date has been that it is not deemed to be appropriate under the circumstances. That in no way is an indication that we don't recognize the seriousness of the opioid crisis. And I have continued to say that if we felt that declaration of a national emergency would give us tools that we don't already have, that clearly we would have a responsibility to do so. To date, we feel that it has not, the lack of declaration of an emergency has not impeded us from using all tools at hand. Having said that, we have in fact looked for other alternatives outside of the Emergencies Act in order to be able to bring further resources and mechanisms to the table. I know British Columbia used their declaration as a way to be able to get better data and surveillance. And so one of the things that the Chief Public Health Officer would be able to speak to if we had the time would be the fact that he has actually taken steps to open a new special advisory committee. We have decided to look at the opioid crisis in the same frame that we would look at an infectious disease epidemic. And so the Special Advisory Committee tool has been used in things like the H1N1 crisis, in the Ebola crisis, and it was actually also used in response to the Syrian refugee crisis. This actually gives the Chief Public Health Officer the opportunity to work with medical officers of health across the country and the public health network across the country to be able to do a much better job than we're doing now, getting as close as possible to real-time information on data and surveillance. And again, I don't know whether you want me to take the time, but the Chief Public Health Officer could give you information. In fact, he is meeting, I believe, tomorrow even with medical officers of health and public health officers across the country to be able to talk about getting that kind of information. So thank you for raising this. The other thing that the committee recommended was a task force, and in fact, I'm happy to say that we do now have a task force within Health Canada, which was recommended by the committee. So these are examples of some of the kinds of things that we're doing to be able to raise this. I will speak, I'm sorry for taking, but I just should respond specifically to the motion that's on the table. And I want to say I would be very pleased to have a conversation with Mr. Brown about this at another time in recognition of the fact that we're here to talk about opioids. I think it's an interesting motion that he's put forward to essentially evaluate a mechanism that was proposed by the previous health minister, who is now leader of the opposition. The process that is currently in place for thalidomide, people who were potentially victims of thalidomide, was put in place by the previous government. The mechanisms by which people would be compensated and by which those who didn't meet the criteria would have opportunity to be able to respond to that. I am pleased that Crawford and Company has been able to identify, I believe, a further 26 individuals. There was one who actually met the criteria as recently as last week, so it continues to identify new people who have suffered as a result of thalidomide. Having said that, if the committee feels it's appropriate to examine the process that the previous government put in place and to assess whether in fact that was a fair process, obviously it's completely the committee's jurisdiction to examine that.
Okay, I'm going to move to Mr. Oliver. Before I go to Mr. Oliver, I just want to say to Mr. Brown, obviously you're really, really involved with this and have a great deal of compassion and concern about it. One of those last ones that was approved by Crawford and Company was in my riding. It was a lady that tried to get compensation for decades and couldn't get it, but she did under the new system. But I just want to say that this committee has considered motions by opposition members many times, and they've been dealt with really well, I think. And I understand how concerned you are and your compassion for this case, and we all do. Everybody at this table does. And we did want to hear from the minister, but anyway, I just if there are issues, we'll deal with them. And I just want to say that. But Mr. Oliver, you're up.
Well, I just echo what you said, Mr. Chair, and we certainly all heard the very impassioned plea for review of the program and what the issues were, but we have set our committee agenda for this meeting. We have a number of other priorities that we have set as a committee. So at this juncture, I would move that we suspend debate on this motion and return to our scheduled committee work, and we could discuss this motion at a later date.
All right, that's a motion to suspend it. But
so I would adjourn the debate.
Yeah, to adjourn the debate on this motion. I'm going to vote for that. I'm going to put that to vote. But I just want to assure you that this will not go away. We'll deal with it again. We'll be glad to hear from you again. So all those in favor of the motion to adjourn that debate on the thalidomide issue at this moment? All opposed? Okay, motion carried. So we're going to return now to the opioid study. And where are we on the speakers list? Mr. Davies.
Thank you, Mr. Chairman. Thank you, Minister. Now back to the opioid crisis. Now this committee heard from many witnesses who told us directly that there's a profound lack of detox and addictions treatment facilities for Canadians, and that this is a critical piece of helping deal with opioid addiction and therefore death in Canada. We know that the people who are dying on the streets are primarily opioid addicts. And so therefore, from a preventative point of view, making sure that all Canadians have access to publicly funded, accessible addictions treatment is a key part on the demand side of the question. Now, accordingly, this committee made 3 separate recommendations in our report to your government that calls for significant new funding for public community-based detox and addictions treatment for Canadians. Now, in your cover letter to the Canadian Drugs and Substances Strategy issued yesterday, you said, and I quote, "I am confident that the proposed authorities, combined with the numerous federal and provincial actions and commitments to date, will help us to address the current crisis of opioid overdose and death in a comprehensive manner." Minister, we have not seen a commitment from your government for a substantial investment in addictions treatment in Canada. So how can you say that your strategy is comprehensive without that?
So I thank you for the question. It's an excellent one, and you're absolutely right that our response to the opioid crisis has to be comprehensive. The content of yesterday's bill spoke in large part to one particular mechanism of treatment, and that being the possibility of further measures of harm reduction, and it was intended to address the currently onerous process that's required by communities who are looking to open supervised consumption sites. There were other pieces in the legislation, as you know, that contribute to the comprehensive strategy on opioids. It addressed our need to make sure that we reduce access to unnecessary opioids and in particular illicit substances. So there's a large part of the bill that related to that. But I'm glad that you brought up the topic of treatment, and I do know that this was raised repeatedly here, and I can tell you that when I meet with first responders, for example, and when I meet with health providers who are dealing with this, that the matter of treatment is one of the most pressing matters. This is an area where I hope that we can find ways to work with our partners to do better. Treatment services fall largely in the jurisdiction of provinces and territories. This is an area where I believe provinces and territories need to do work to open more facilities and make those facilities more available. You know, for instance, that we are in the process of negotiating a health accord with the provinces and territories. I have made it very clear to them that issues of mental health and addiction are very important to us as a government, that we would actually like to be able to invest and to provide further support for them to do better in terms of providing mental health care and addiction. I have not we could do to hear more from the provinces and territories about how we can help them, what their plans are to open more treatment services, and that would give us an opportunity, hopefully through the Health Accord and our commitments to mental health, to be able to fund to invest in better supports for people, both in terms of preventing addiction by treating mental illness at its roots, but also by providing addiction services. So
Thank you, Minister.
I hope you'll hear more on that soon.
Okay. Now, your government has commendably made a substantial increase in funding to the Global Fund to address HIV and AIDS on the international stage. Unfortunately, your government has recently denied or cut funding to many HIV support organizations who provide services here in Canada, including some who are key players in responding to the opioid overdose crisis. Will you commit to reversing these cuts and ensure that every group who has historically received funding under the Community Action Fund gets that funding? And a short answer would be appreciated.
Yes, I think you are aware of the fact that we have been working with agencies who were potentially going to have an interruption of their funding through the Community Action Fund, and I asked the Public Health Agency of Canada to speak directly to each of those organizations and to continue their funding. We are committed to continuing to support those organizations through to 2018. In the meantime, I am seeking further resources to be able to expand our federal approach to sexually transmitted and bloodborne infections, including the Community Action Fund. It's my hope that we will find mechanisms to continue to support these excellent agencies.
Thank you, Minister. Now, Minister, as you know, increasing home care services to Canadians is a critically essential innovation for our healthcare system, and I'd like to ask you about it. I'm going to quote from the 2015 Liberal platform in Chapter 1. Quote, "We will negotiate a new health accord with provinces and territories, including a long-term agreement on funding. As an immediate commitment, we will invest $3 billion over the next 4 years to deliver more and better home care services for all Canadians." Minister, as is crystal clear from your platform, the Liberals' commitment to $3 billion for home care was entirely separate from the Health Accord and was promised to commence in year 1 of your mandate. Yet here we are entering your second year in office, and Canadians have not seen a nickel of federal money for home care, and you have tied the home care funding to the Health Accord negotiations. Why have you not kept your election promise?
Thank you for the question, and you know that we are committed to making sure that our investments in health will improve health systems across the country, and it's well known that investing in home care will allow provinces and territories to get people the care that they need in a more effective manner. So we are firmly committed to the $3 billion on home care. We wanted to do that in collaboration, of course, with our partners in the provinces and territories, and therefore we have included that in the negotiations toward a health accord. I had certainly, I'm still optimistic that we will be able to wrap up those negotiations as quickly as possible, but it's taking some time to be able to come to those arrangements, and it's my very firm hope that we will finalize a health accord that will include the home care money. I think it's essential that we get that investment into the next federal budget, and certainly if all goes well in my discussions with the provinces and territories, it will be there.
Time's up.
Thank you.
Dr. Olson.
Okay, thank you, Minister, for coming in.
I think I have to cabinet started 5. Can we make, sorry, can I just do a quick question?
I'll do a quick question. Okay. Absolutely. All right. Could you compare the question may be hard to answer, but it's not a long question in itself. Under the previous, when all the provisions of C2 were in place, there were concerns that there was an extended timeline it would take to approve supervised consumption sites. By removing these barriers, can you comment in general terms on how that's going to change the timeline for approval of a new site from how long to how long? Like how much time will be saved by these changes?
That's an excellent question. What it speaks to is the fact that the current process is terribly onerous and has made it very difficult for communities who really want these sites to be able to receive an exemption, and it takes a number of months. Now, having said that, As I indicated earlier, it's generally not because the federal government is opposed to providing that exemption. It's because often the barriers to getting those sites approved rests in, for instance, the municipality getting zoning for the site and getting the work done to be able to provide secure systems, etc. So in many of the cases where there's been a delay, it's because of actions that we're waiting for on behalf of municipalities or sometimes provinces. Having said that, one of our commitments in the new under the new system will be that we will institute a service standard, that we will institute an expectation as to the period of time that it will take, and I'd be happy to give you further information on that, but I think it's very important that we provide some assurance that we will deal with these expeditiously.
Well, thank you, Minister.
And I'm sorry that I have to leave. As you know, will always be available to respond to members' questions, and I thank you for the time today.
Well, I want to thank you for your answers, and I want to thank you for answering our questions about the opioid crisis and also for addressing Mr. Brown's question. Thank you. I can think of other ministers in the past that might not have been so open-minded as you have on that, so thank you very much.
Well, these are important matters, and thank you for working on them.
We all agree. For 5 minutes while we change tables and witnesses. reconvene our meeting, and I welcome our guests back from the Parliamentary Budget Office, and we're certainly looking forward to the testimony. I'm sure it's going to be very interesting. We have Jean-Denis Frechette, the Parliamentary Budget Officer, Mustafa Askari, Assistant Parliamentary Budget Officer, Carly Melanik, Financial Analyst. We have Jason Jacques, Director of Economic and Physical Analysis, and Mark Mahabir, Director of Policy. And the point of the meeting is to get an update on your proposal or our request to have an analysis of the National Pharmacare Program. So we'd like to hear for an opening statement of 10 minutes, and then we'll go to 7-minute questions. So you're on.
Thank you, Mr. Chair. Merci, Monsieur le Président, Messieurs.
Thank you, Mr. Chair, Mr. Vice Presidents, ladies and gentlemen of the committee. Thank you for this invitation to appear before you to discuss the work undertaken at your request on estimating the cost of the creation and administration of a national pharmacare program.
In advance to your committee, and we will be pleased to answer your questions if you need some clarification about the required resources, the timeline, or the methodology. Just before, I would like to mention that to develop those terms of reference, my colleagues Carly and Jason have met and discussed with many of the stakeholders mentioned in your motion. Mark and Carly have negotiated some potential agreements that will be required for obtaining appropriate data and information. In the terms of reference, you can note that the project will require 2 full-time analysts over an expected 6-month period, and that the total cost of data from various sources will exceed $100,000. Although such an amount could be planned in the Office of PBO's budget, it is worth noting that I do not have the signing authority for any amount exceeding that threshold of $100,000. In those circumstances, the Library of Parliament has to submit a request to the Senate and House of Commons speakers for their approval in principle for entering into such a procurement process. Of course, I do not know what could be the outcome of their decision, but I will have to take it into consideration for the future of this project. Thank you, Mr. Chair. I stop here. We will be happy to answer all the questions you may have.
That's the shortest opening statement we ever had. So, so we're going to go to who do we have?
They're debating that.
Pardon?
They're debating that, I think.
Oh, okay. We're just debating the speakers here, I guess. Dr. Olson, you're up. 7 minutes.
Okay, thank you. So, in regards to what it would cost, now I'm sorry, what you're talking about with the cost of full-time analysts. Can you describe what other information you need from us in instructions at this point for the costing?
In terms of the costing?
No, as in the cost, yeah, the whole framework of the initial assignment.
Okay, if your question is about what it will cost to the PBO, is it really?
No. What I mean is, with the study of
the study itself.
The study itself, yes. So what other information you need from the committee at this point to proceed with the study?
We don't need any more information for the moment. I mean, those are preliminary terms of reference. There's a reason why we mentioned preliminary terms of reference. It's really because they may change over time, or we may see our methodology or the access to information that is required may not be available or whatever. So, I mean, those are the terms of reference that are in front of you are what we plan to do for this committee.
Mm-hmm. All right, and so you have said that it would take 2 full-time analysts 6 months. Would you anticipate there might need to be an extension to that time, or do you think 6 months is a adequate time for that, or is that too loaded a question?
It's always the big question. It's the $100,000 question, I guess. For the moment, that's what we're planning. But as we know, in the course of a project like that, which is a complex, which will require a lot of discussion with stakeholders and so on. Stakeholders being those having the data that we need for the study. It may take a little bit more time. We will certainly debrief you on a regular basis on where this as a status report during the course of the study. Mm-hmm. So for the moment, we're looking like June 2017 as the preliminary deadline.
All right. And at what intervals would we be receiving updates? Monthly, every 2 months?
Mustafa will answer.
I suppose it depends on the committee's requirements. I mean, typically when we start a project, we go and work on it and finish it and then report back to the committee or the member. But in the meantime, if the committee would require some updates on where we are and what the status of our analysis is, we would be happy to come back and provide that, or provide that in writing to the chair.
Mm-hmm. All right, thank you. At this point, I'll yield my time to Mr. Oliver.
Just a question around aggregate. You're estimating the net cost of the federal government, so the net cost, and you say in one of the bullet points that all aggregate costs and projections would account for opportunities for savings. So I just want to confirm that we know there's a significant spend already happening in the public sector for benefit programs that would no longer be required if a national pharmacare program were continued. Were created, and also there's a spend in the private sector to provide private drug plans to employers that would be able to be converted now and turned into the public system. So are those costs going to be identified and brought forward in the estimates of where both offset costs for government and also potential sources of funds?
If I can just make sure I understand the question correctly, when we're looking at the aggregate costs to the federal government, you're wondering if we're going to include the portion that's currently spent under public programs as well as the portion that's spent under private programs?
Correct.
Yes, we would.
Okay, excellent. And in terms of the cost of the study, the $100,000 includes the cost of data purchases, and you note in your material that the data that you acquire would be your property then and would have continued value. Do you see, besides this study, do you see other value from that purchase of data?
We hope so. It certainly is. It will exceed $100,000. I mean, that's the threshold. It's going to be exceeding the $100,000. We know that for now. I mean, in terms of the preliminary discussions we had so far. So we hope it's going to be useful for other studies in the future. We will, and that's why we have this condition of being the owner of the data for future use for whatever reason.
Okay.
The problem will be to have access to that. To those data and to pay for it. Right now we are facing, just to be clear if I may, Mr. Chair, we are facing two situations. We need to negotiate that contract, which will be over, as I said, $100,000. I'm also negotiating with the Quebec government because, as you know, the model that you propose to the PBO is to use the Quebec pharmacare system. And we need their Excel files to have access to all the list of not only the drugs covered, but also the price paid, not the price paid at the retail, but the cost paid by the system over there. And we are in negotiation with the Quebec government right now in terms of accessing that kind of information. Otherwise, if we don't have that, it's going to be very difficult. We do have the PDF documents of all these 8,000 or so drugs that are on the Quebec list, but the PDF, thousand of pages. We need Excel electronic files for that.
Okay. And then in terms of estimating the cost, so you'd be using the Quebec cost data, but we know that Canada is currently the second highest payer for pharmaceuticals in the world, or in the nation we compare to. Are you looking at any models of how a national program would be able to negotiate different prices? Are you building in sort of thresholds around a negotiation of pharmaceutical prices and giving sort of what the projections might be that with a national program we get lower costs?
Carly, Jason?
I can answer that. It's certainly in our methodology to attempt to incorporate that, but this is all going to be contingent on what actual data and information is available. But it's certainly in the methodology framework currently.
Thank you.
Okay, we're going to Dr. Carey.
Thank you, Mr. Chair, and I want to thank the witnesses for being here. Mr. Frechette, I hope you don't mind, but I'm going to push you a little bit more on that word exceed 100,000. It seems very low to me, and I was wondering if you're looking at that. I always get nervous when you give a number and then it's expected to exceed. And I have a lot of confidence on your predictive abilities. I was wondering, like I'm just looking at 6 months, 2 employees, having to buy all this data. Are we looking at, is it going to be triple? Is it going to be 10 times the amount? Did you have any general idea you could give that information to us?
Yes, sorry.
Sure.
Thank you for the question. The $100,000 is only for the data. It's not the total cost of the project for this committee. It doesn't include the two full-time equivalent that will be absorbed in the normal operations of the office. It doesn't include any overtime and so on. The $100,000, just to be clear, is to buy the data.
Okay.
And the information that will be required to conduct that project. And as I said, it's going to be more. A single contract will be with one company will be over $100,000. Mr. Chair, I prefer not to mention exactly the amount. Of course, it could go to $1 million. It will not go to $1 million. But what I said is really it's going to be over $100,000, which is a threshold that I cannot sign for. Mm-hmm. So I will need a special authorization if we go there and sign a contract of that sort.
And for that process alone, that would have to go, what is it, to, I don't know, the Senate, or you said we would have to make application for that? What the length of time that process would take to okay that, do you know?
I don't know, and that's why when I was asked the question about 6 months, I mean, essentially, you have all these different factors that will have to be considered. When the Library of Parliament, we being the PBO and Library of Parliament, submit this request to the two speakers, we are in their hands, and it really depends on their decision and how. And I don't even know what the outcome of that decision. They may decide just to refer it to the liaison committee. They may decide to just wait, make an analysis of it. I have no idea how long it can take.
Well, I see there's a lot of uncertainty out there, and even the quality of the data. I've been trying to make the point that we don't even know kind of what the problem is and what we would be addressing. And you mentioned under the data section there, there's key assumptions that you would have to make, I suppose. Can you give us a quick little opinion on what do you think, now that you've had a few weeks, what do you think of the quality of the data out there? Do you have an opinion on that or thoughts on that? I guess Carly?
So we've only started looking at like mock data and things because we haven't actually purchased the data yet. There are several metrics available from both public and private sources. So at this point, I can't really comment on the quality, but from what I can tell, there's been several years of analysis done on this data and data collection, and several metrics available as well.
Okay, so we're still unsure just the quality of data that's even out there, because I'm looking at the cost here, and even your timeline. If we were able to get it in by June 2017, which I don't think we could, because as we go through government processes, usually it takes a little bit longer than we all think. But even if we gave it another, let's say, a year, do you think once we got that data, we could even come up with some type of program that the government could actually even implement in this current mandate?
Well, what we can offer at the end, if we can stick to the terms of reference that we have, is that we can provide a framework and a cost for that framework. Now, that may have to be then decided, and from the policy perspective, it has to be decided by the federal government, the provinces, how they're going to implement that. Mm-hmm. because as you know, the provinces have their own programs right now. So how they're going to fit that within that their own program, that will require certainly discussion and debates and negotiations. But this will give an idea to those who are considering this kind of a program, is that what is the overall cost of this? And then from there, you can go ahead and design a policy that would provide this kind of a service. Once the policy is decided and designed, then we may have to go back and reevaluate the cost and the different aspects of that.
Yeah, you brought up a really good point talking about the provinces, because there's another timeline. If there's going to be any negotiation or discussions with provinces, that could take years. What I've been trying to do to get the committee, the government side, to come up with possibility of maybe narrowing the criteria, or coming up to see, get some input from the minister to see what type of ideas she would be acceptable to her. It's almost like chicken and egg type of thing, because as you said quite correctly, we could do all this work and then the minister may say, well, we're not even sure if we want to go that route, so maybe we'll do this instead. Can you go back on that? We could go back and forth forever. But if we were able to narrow criteria and maybe get some policy direction from the government ahead of time, instead of, you know, just doing this, like the old saying is, shoot and then aim, would that be helpful on decreasing some of these timelines and maybe the costs?
Certainly. I mean, we normally prefer to cost programs that are already in place or have been proposed by the government, because then the elements of the policy are known at that point, so it would be much easier to cost it and, you know, more effective to cost a program like that. This is an idea, so the elements of it are not really clear to us. And we have with the direction from the committee, we have come to this terms of reference. Whether the final product or final policy is going to look like this or not, we have no idea. Certainly, if we have better direction in terms of the actual policy design, it would help us. And,
well, I think that would make sense to anybody looking at moving forward. But would it make sense to you maybe if we suspended the study until we got your information and the expense report or something along those lines? Because I'm just nervous about going around in circles and what's this going to end up costing us.
That's obviously up to the committee. You know, certainly whatever you decide.
Oh.
Time's up. Mr. Davies.
Thank you, Mr. Chair. Thank you for being with us here today. I've reviewed the document you've prepared for the committee, and a couple things I want to clarify. You do not have to purchase data from the Patented Medicine Prices Review Board, Statistics Canada, or Health Canada, correct? No. Any data from those resources will be free.
Typically, no. Sometimes Statistics Canada does have a standard fee, as well as the Canadian Institute for Health Information. It's very low. I believe it's something around $250 an hour. But this is usually standard for their cost recovery fees.
Okay, no, I specifically didn't mention Canada Institute for Health Information because what I'm trying to find out is, who do you have to purchase data from? Let me try it that way. Who do you have to purchase data from?
The main expenses, the $100,000 we mentioned, is from the IMS Brogan.
From who, sorry?
Quintiles IMS, now called Quintiles IMS, which is one of the stakeholders that is mentioned in the in the motion, and they are basically the only provider of that kind of data across Canada.
So sorry to be clear, that's the only organization that you have to pay for data.
That kind of amount, yes.
Yeah.
Other organizations, as Carly said, like StatScan and CAI and so on, we have some kind of a relationship, and some of the data may have to be paid for, but you're not talking about, a lot of money.
Well, and I was going to say that one federal department paying another federal department is a wash at the end of the day, isn't it?
It is, but that's the way it works sometimes.
Yeah. And can you describe in general terms, what is the kind of data you need to purchase? What is the category, or what are you looking for?
Specifically, we're looking for, of course, the drug level pricing information, and this is so that we can match any particular formulary, in this case Quebec's formulary. And then as well, because the committee was requesting some statistics on patients and their information, we're also asking for information on those individuals, such as their age and gender and things like that.
Okay. I wanted to shift a bit to your document. At the top of page 2, you recite the exemptions that this committee had instructed. I just want to be clear on this too. You say the criteria for exemption of the copayment include, and then you listed some criteria there. This may have been the committee's lack of clarity, but I think what we wanted to do was match the exemptions under the UK model was the instruction, and then I think we gave you some examples, because what I'm concerned about is that these 4 bullets are not all of the UK exemptions. So I want to clarify with you, are you clear on your instructions that you are to apply the UK exemptions in their totality?
I don't think we were clear on that point, but some of these exemptions also, I think the committee has to know that once we start announce it and go through the estimations, we may have to modify some of these things because some of them may not be possible to do in a sort of a credible way. For example, I just use an example. For pregnant women exemption, I mean, that's going to be very difficult. You have to make some assumption what percentage of the population is going to be pregnant, and then how you're going to apply that. And one issue there, of course, is also the pregnant women are exempted only for the drugs that are used for their pregnancy, or they're exempted for all the drugs that they use for other reasons.
Well, again, and I would probably leave this to my colleagues, but my assumption was that we would simply, for ease of reference, simply apply the UK exemptions, because obviously the UK would have that figured out. The UK either exempts pregnant women from the copayment for drugs related to pregnancy or generally. But my main concern was that this list is not complete. It doesn't include children under 16, as you've recited it here. It should include children under 16. Students are, I'm told, is not between 16 and 18, but 16 and 19. And also, I think veterans are also not listed here, or people with long-term illness. Anyway, my point was, I think if you need clarity on what exactly the exemptions from the copayment are, the committee should give that to you. That was, but because you said include, I wasn't sure if you were just showing some of them, but you were aware that there was a broader category, or if you only mean those are your exemptions, and I think we'll have to clarify that.
Okay.
I was going to just give a little statement that, you know, I don't have the actual numbers here, but we know we spend tens of billions of dollars a year on pharmaceuticals in this country. We've heard estimates that a national pharmacare program could save between $4 and $11 billion a year. So to me, to spend $100,000 to collect data that would be useful to the government to have in any event, I think is, you know, is not only a bargain, but it's, in fact, it's a responsibility of us to do that. You did mention in your report that this data would be retained by the PBO and would be useful, I think, not only to the PBO, but to the Ministry of Health. I mean, to know how many Canadians don't have coverage. That's been a concern raised by my Conservative colleagues. They doubt that we have accurate data on how many Canadians do or do not have coverage. You know, to gather the data on how many, you know, what a national formulary would cost, I think is just superb information for the government to have in any event, and may inform public policy. So my question is this: do you regard gathering this data as being of some utility to the Ministry of Health or other ministries in any other respect?
I'm not 100% sure, but I believe the Minister of Health has already, they already have access to that data that we are trying to purchase. My understanding is that they do get
Can they not share that data with you then for free?
They probably not, because their contract probably does not allow them to share that data with other organizations. I don't know, but that's something we can.
Could you check into that?
We can check.
I mean, if the ministry, if you're, you didn't say 100%, but if you're quite sure that the Ministry of Health has this data, that the government's already paid for. One would think that we wouldn't have to pay for it a second time. Hopefully not anyway. Can you look into that?
We can certainly check and make sure, but they may have the data in a way that may not be directly useful for us, and we may need a certain way of gathering that data or putting that data together that this private provider would do that for us. But they may have access to the raw data, but not the way that we want it. So we can certainly check for that.
Thank you.
Okay, time's up. Before we go to Ms. Sidhu, I just want, have you had a precedent for a study that you did went over $100,000 and you had to seek more funding? Has that happened before?
Not for a study. For a court case in 2012-13, yes, but not for the study. Just want to, if I may, Mr. Chair, the member raised a very interesting point in terms of the access to information. If the department does have the information, of course, I mean, we can ask this committee, because you have the power to call for papers and people and including data. Then which is something that we do for all the studies that we work for, either for individual parliamentarian or for a committee. This is preliminary terms of reference. I mean, we debated among us whether we will call it terms of reference, draft terms of reference. We came with preliminary because this is work in progress with this committee. At one point, we will present hopefully a final terms of reference that will be approved, or at least satisfy the members of this committee, including the cost and including these what it includes or not. And that's the normal procedure. And at that point, then we can move on and so on. For the access to information, I mean, it's still to be debated whether or not we will be able to have access to the department data.
Okay, thank you. Ms. Sidhu.
Thank you, Mr. Chair. Can you talk a little bit more about the past successes, barriers, and issues with buying data sets for other studies? And also, I want to echo that again, is there any role for the committee to helping you engage with the provinces or anything as a committee or minister can do?
In terms of negotiation or discussion with the provinces, it's looking good so far. I mean, I had discussion last week with the Quebec Department of Santé, Department of Health, sorry. So that looks okay. I mean, we're exchanging, and they're quite open in terms of providing some information. The other type of information, specific information, owned by the only firm in Canada that owns these kind of this kind of data and information on both private public coverage. I mean, Carly, and as I said, Carly and Mark is the legal counsel in the PBO's office. We're looking into all the agreements and making sure that we're going to get the data that the taxpayers' money will pay for. So I mean, we're really careful about that. That's about the answer I can give you. I mean, that's the only source right now that we have to negotiate in terms of purchasing expensive data.
Thank you. That's it, Mr.
All right, thanks very much. Mr. Weber.
Have a whole lot of questions here either. I think everything was covered. I do just maybe want to ask our committee how we went about choosing Quebec as the formulary to study. Was it just a random thing, or is Quebec one of the more generous formularies out there? Or do you recall at all why we chose Quebec?
So as you recall, we had a meeting and there were several options, and in our Quebec was one of the provinces put forth because it was on the more generous side. There was some potential that it was my understanding that there had been some work done on what is referred to as an implicit formulary, as there's kind of a working national formulary, and if the PBO could have access to that, they could either use that, but if that was not available or feasible, then they could use an existing provincial formulary, and the committee, when they made their decision, they chose Quebec because it was a more comprehensive formulary.
I see. Well, thank you then. any idea of whether or not it would be easier to get data from another province? Is Quebec maybe more difficult to get that information? I'm just throwing that out there. I know it's a question that you probably can't answer, but I thought about it anyways, especially for $100,000. It seems like a lot of money for collecting a list, a formulary, which I would think would be quite well known what is on that list, and also the cost. A question about the cost. Is there some confidentiality issues with respect to letting Canadians know exactly what they're paying for these drugs? I know that there's a lot of negotiated pricing that goes on, and a lot of it is confidential. Will there be issues with respect to confidentiality with pricing with the drug companies that they've negotiated deals with?
Thank you for the question. Just to be clear, the Quebec government will provide, according to my latest discussion on Friday, will provide the information that we need for free. I mean, there's no cost there. It's only a matter of having the proper support. As I said, we need the electronic files. It's easier to work with and so on for the model. So, I mean, the cost doesn't come from the Quebec government. Your question about anything that has to do with federal provincial issues these days, particularly last week, because of the negotiations on the health program and so on. Of course, I mean, it's always a sensitive issue, but for the moment, doesn't seem to be a problem. Let me ask Mark about confidentiality. Mark is power of legal counsel. Will give you all the information about that.
Thank you for the question. We will be using a composite price, so the price will consider all the provinces' costs, but will not identify the cost for specific provinces.
Great. That's about it for me. I don't know if I can share some time, if a colleague...
Minute 40 seconds.
Any?
So sorry, just a point of clarification then. You're saying that the database that we're seeking already exists, just in another department? Am I understanding that correctly?
I said that I believe the Department of Health has access to that kind of data because for their own purposes, their own research and regulation of drugs, they always have access to all kinds of information about pharmaceuticals. So I'm assuming that they have access to that data, but I said we can check with them to make sure that if they have it, they have it in a form that would be useful to us, and whether they can actually share that with us. Do you want to add?
Yeah, the data that Health Canada has may be old. It may not be recent data. So what we're getting from the provider would be recent data.
Okay. So is there, these questions need to be clarified for us before we can make an educated decision with regards to going ahead with this study or not. So is it possible to have you come back to the committee with an update on that, whether or not this data is in fact accessible, and two, just exactly what year it's from?
We can certainly check with the ministry, with the Department of Health, and see what the data they have, and then whether they can actually legally share that with us, because they may be under contract obligations not to share that data with anybody else, and then what year, how up to date that data is, and certainly we can inform the committee on the results of that.
Okay.
Time's up.
Thank you.
Thank you, Mr. Oliver.
Following up on Ms. Harder's point, would the committee have capacity to require this information to be provided from the Quebec government? Is that part of our authorities, or?
We have that power.
Have you seen that? Would that be an appropriate exercise, or is it mostly done through contractual?
I assume the request would come from the PBO, and we would get the information that you need.
Okay. The other question I had was, I'm just wondering how we move from preliminary to final terms of reference. So Mr. Davies identified some changes to the exemptions, just to make sure that we had the same as the UK list of exemptions. Are there any other specific items that need further input from the committee besides the decision on the cost to move this from a preliminary to a final terms of reference? What else are you looking for?
I guess it's just all in this discussion, basically. So Mr. Davies pointed out some changes to the exemptions, but really we presented this to the committee to incorporate what we thought we could from your letters detailing some of the parameters, and also based on our research of what data is available and what is out there and what our stakeholders believe us that we can also do with that data. And now we've presented it back to the committee. And again, I suppose it would be up to you to agree to this so we can continue on this path of continuing this research.
So just to ask again then, other than the list of exemptions, I'm not hearing anything from around the committee that disagrees with these terms of references. So if we get back to you with that, can we view the terms of references finalized? And
if that is your wish.
Okay. And if in the decision is made in the end that we need to spend the $100,000 and need to purchase it, would a letter from the committee chair to whoever the deciding body is that would allocate resources, would that be of benefit to you in seeking the funding for the study?
It's an excellent question, because as I mentioned, I mean, the approval in principle must be done by the two speakers, so the Senate Speaker and the House of Commons. So I refer to the clerk of this committee and the administration and this committee to whether or not they want to, send something to. I assume there's no problem to send a letter to the Speaker of the House of Commons. I'm not sure about the procedure to send something from this committee to the Senate side. If I may, just want to come back to what you mentioned about the department. I mean, what we can do, which is, we can put an information request to the departments about, whether or not they have the information, which is a normal procedure. We often mention, the committee that we are doing work, we're doing an analysis for a committee, and therefore we need that kind of information, and then we wait for the reply from the department. And the difficulty here will be to see if the department is willing to share in advance, at least to look at the data that they have. Is it too old? Is it appropriate for the kind of study we're doing for this committee? So there will be, I'm pretty sure, some kind of negotiation there in terms of looking at the information in advance.
Okay. So who's going to lead this? Is something that you're going to lead then to sort through these questions? I mean, if we can bring the price tag below $100,000, we proceed with the study and we're moving forward. So I'm just not sure how this comes back to the committee to make sure we're ensuring that the study is getting done.
I assume that the best approach will be to keep this committee informed of the most recent development. Go ahead with a request of information to the department to cover your request. Continue our negotiation about, having access and paying for the data from Brogan and see how much that could cost, and provide that information to the committee. Of course, then, I would prefer that if it's a contract, I would prefer that remains at least between the committee and the PBO, because I'm not sure a private company needs to be, wish to be known how much they sell the data and so on. But that would be the process. So we will keep the committee informed of all the developments, and maybe a status report when Parliament comes back.
Thank you.
We have
Nobody from the Conservatives.
The Conservatives. Ms. Harder.
Thank you. I have a question. I'm hoping that perhaps someone from up here can answer this question. And that is, with regards to a cost for a study, who goes about approving that? Do we just have money at our disposal and we can just say, yes, go ahead, make the study happen? Or do we have to go back and get approval for financing?
Santa.
Well, I know, right? Endless money.
Normally, when we do committee studies, it goes to the liaison committee. If it's under 40,000, usually it's approved. If it's under 40,000, it's a different process. The chair usually has to present the budget to the liaison committee for approval. So that's the usual process for studies.
Okay, and
that we normally follow.
Okay, and so how long of a process is that?
The one that I just described?
Yes.
Well, if it's a study under 40,000, it's usually very quick. Well, the committee has to adopt the budget that we present, and then usually it's approved. So that's
So in this case,
a couple of days, but
over 40, so the chair will have to take this and present it. And
well, I think that this one is different, as the PBO has explained. It could go there. Well, from what I can understand right now, it's more in their court, if you will. And he described to the process. Maybe the PBO can answer better that than me, because it's part of their mandate. They have a different process than we have.
Okay, so then essentially if we say yes, we want this study done, then the PBO eats that cost without any further discussion really necessary or approval required?
It's the plan, and as I mentioned, we will absorb it. Of course, we cannot absorb, $500,000, but if it's something a little bit over $100,000, for example, we plan to absorb the cost and do the study and own the data eventually. But there is this threshold that I don't have the authority to sign for this kind of contract. The contract will have to be presented to the speakers of the Senate and the House of Commons.
Okay.
Which is the normal procedure. The library, the PBO has never done it for a study for a committee, as I mentioned before. The library did in the past add some contracts, I believe it was the IT contracts or something like that, that they had to send for approval in principle, which is part of the briefing book that the library prepares and I prepare for the speakers every time there is a new speaker. So approval in principle means they have to review it. It's part of the normal procedure of my signing authorities.
Okay. So I guess I'll speak to my colleagues now. Given that this study could cost, well, definitely over $100,000 and upwards from there, would it not make sense then to bring the minister in at this point and ask for further direction with regards to the formularies so that we're actually giving her information that her department would seek to know? Would it be possible to bring her to the table or to request that she write us a letter with some further direction? I'm not opposed to spending money, but I'd like to spend money in the right direction so that we come up with a product that her department is actually going to find useful.
I think that she would respond to any request like that, either of those, I think. She's very interested in this. I mean, this was our choice to make the study, but she's interested in it, I know. So I think there'll be a very cooperative attitude in the department and in the government to see where this goes, because we've had estimates actually from $0 to $11,000 million saving per year. And if you talk about it's just on an average of $5 or $6 or $7 billion a year, this is a very small amount of money.
So
you're welcome.
Could I guess I'm looking for some action on this. We can all leave here today, but then nothing got accomplished. So could we agree to write a letter to the minister asking for some information with regards to where she'd like to see this study go, the type of formulary that she would like to see followed?
I'd suggest we write a letter to her explaining what the PBO has proposed and see if she agrees with that.
Normally that letter would be written by the chair and submitted through the chair, but it would need the recognition of this committee to move forward with that.
Fine with me. Now, we still have Ms. Harder's time.
It's a point of order. I'm with all due respect to Ms. Harder's time, which she can continue if she wants, but I'm unclear where we're at in this. Ms. Harder seems to be asking a question of her colleagues to discuss. I don't know, do you want to have that discussion now, or do we want to have that maybe in committee business after?
It's actually committee business.
Can we defer that question then to committee business and then discuss it?
Yes, we'll defer it. So
because I have some views on that, on what her question is.
So, Mr. Khan. Mr. Khan, yes.
Thank you, Mr. Chair. My questions are around the cost to $100,000. And, you want to get the data and some other costs. And were there any problems you had deciding what data to get, or any pushback not to get the data?
In our discussions with the data holders, so Quintel's IMS, it hasn't been really so much pushback as a dialogue around what data is available and how we could receive that data. And I would just like to put out a general statement there that The data that we're requesting does allow for some flexibility around sensitivities. So right now we are moving forward with applying a Quebec formulary, but there would be potential to actually use like a different formulary. So I just thought I'd add that.
So how reliable, like I hear that, some of the data is old, or, how reliable the data will be, the one you will be getting? Is it, pretty up to snuff, or?
Right now, it's our understanding that we would have data available for a full calendar year for 2015. If we wished, we could get partial 2016 data, but I think we're going to look towards the 2015 calendar year. And this would include data from the Canadian Institute for Health Information for the same year as well.
Okay, and my understanding is that you will be basing this on the Quebec model, formulary. Is Quebec formulary, is the Cadillac, a model, or the middle model, or lower model? Will it be implementable? If we use that model, like cost-wise, is the Quebec model covering all the drugs in general? The Canadians are going to need. That's my concern on the Quebec model. Or will we have to, add drugs to that formulary, or maybe take some drugs off the formulary? Or?
So we haven't started the detailed analysis comparing the different provincial formularies. We're right now just running with a Quebec formulary. But again, the data that we're purchasing will allow for application of additional formularies, and it's in the plan for sensitivity analysis to at least understand what Quebec's formulary is compared to other formularies with the list of drugs and things like that.
So that will be literally like, kind of just step in the right direction and not the final approach?
No, so we would still certainly look for our project will be based on using a Quebec formulary. But we will, of course, look at what that formulary means in terms of how many drugs are being covered compared to how many are being sold in Canada and things like that. But all of the calculations will be based on using the Quebec formulary.
Okay. And can you make the technical methods available to the committee? Like, for example, equations, estimates, once this is decided, can you share all the information with the committee?
I'm sorry, could you repeat the question?
Okay, all the methods you're going to use, all the methods, to come up to, come to certain formulary, and the cost, will they be shared with the committee before the final document comes out, or?
Typically our reports, whatever costing we do, has a section at the end, normally in an annex, which explains the methodology that we have used, the data sources, and any other thing that is related to the report. But we do not typically provide sort of the daily sort of update or a monthly update on those kind of a thing. Once we have a clear direction in terms of the terms of reference, we go and do our reports, and then we'll submit the final report to the committee.
Okay. And we talk about jurisdictional issues, provinces and territories, and what kind of challenges do you think we're going to face? When we come out with this pharmacare, have you given it any thought? Like,
jurisdictional issues in terms of the provincial jurisdiction,
yeah,
you mean?
Yeah.
Well, what we are doing right now has nothing to do really with the provinces in general. The only thing we need from the provinces is from the Quebec to get a list of their formularies in a sort of digital form so we can use it. This cost is a national pharmacare program cost. Now, how it is going to be structured and managed as a policy, that remains to be seen. This is not dealing with that issue at all. This is just saying that if the federal government wants to establish a national pharmacare program, which will cover with the coverage that we have mentioned here, what would be the overall cost of this now and over time. And then obviously the next step for the federal government, the provinces, would be to negotiate some kind of a structure that they want to establish to deal with that and deal with the current programs that the provinces and territories have.
Time's up, Mr. Chairman. Mr. Davies.
Thank you. I think most of my questions have been covered. I'm not sure that I fully understood the answer on Mr. Oliver's questions about keeping this under $100,000 and whether that's possible. If I understand correctly, though, if it is under $100,000, you don't need the special authorization. Is there a way then? So could this committee give you direction to request that you spend up to $99,000 collecting the data?
Tax included.
Always.
Always.
Always. And then see where we're at, or
we're back to this question about the quality of the information and the required information to do to use for the model and the projections. That if the committee, I'm in the hands of the committee. Of course, the committee can ask PBO to do whatever and spend only $9. Doesn't matter. You can have the quality or the availability of data for that amount of money.
Well, I'm wondering, do you have to purchase the data in one fell swoop that would be over $100,000, or can it be done in an incremental way? So for instance, could you, if we said spend up to $99,000 and see where that takes you, and then we can always come back to the committee, say 3 months from now or 4 months from now, and then purchase additional data, or do you need to purchase it in one fell swoop at the beginning?
Depend on the contract. With some companies, it is possible to split, for example, over 2 fiscal years. It's not always possible. In this case, we don't know. As I said, we're still negotiating the contract. Sometimes, and I'm back to this procedure or this assigning authorities. I mean, it's very difficult for me to say I'm going to spend $90,000 in fiscal year 16-17, and then I'm going to spend another $1,000 on April 2nd, just at the beginning of the fiscal year. You see the problem. You see the situation. I will be looked at, and in my signing authorities, even though I would respect technically this signing authorities, it will not be perceived as totally being fair.
Okay, I'm not sure that I'm not asking, assuming you spend over $100,000, how do you split it into 2 fiscal years? I'm trying to ask if we can keep the global amount under $100,000. And I'm just wondering if you can is it possible to go to the company, say, we want to purchase data for $95,000, get that data, and then see if that's sufficient, and then if not, come back to the committee for additional money? Is that possible?
Additional money from the committee. The committee will not provide for the moment. The agreement is not that the committee will provide any money. The cost will be
right.
So I don't know if right now the PBO does not ask any money from this committee. We will. It is if we have to spend that amount of money, $90,000 or $50,000 or over $100,000, we said that we can plan it within our budget, which is I did so far. I mean, it's planned in the budget.
I see.
We certainly can do increment. I say certainly. I'm looking at Mark at the same time. We may try to negotiate, a series of contracts over time, but then the limit of 6 months will not be respected. I'm pretty sure.
Mr. Frechette, when do you think you can come back with the more finalized terms of reference?
Can I get back to the committee on this? Can we discuss that in the office?
Thank you.
Okay, well, that concludes our session for questions. But I have one question myself. And when you say it has to go to the speaker, does the speaker himself decide, or does he have a committee, or is it just the speaker?
It is. The process is the following. We the Library of Parliament, we have a contract. Before signing the contract, we send it to the 2 speakers, and in their procedures, it's written for approval in principle. This is the wording that I'm quoting, and then they make a decision on it.
Okay.
And I don't know. The decision can be no. The decision can be yes. The decision can be the two speakers will refer it to the liaison committee, or just, I don't know, I have no control over the decision, of course. I mean, it's their decision.
Well, thanks very much. Just to put this into perspective, I read a headline this morning in the Hill Times that we just spent $134,000 to have dinner with the Mexican officials, and just to put that into perspective. And we're talking about a healthcare issue here that could possibly save, we don't know yet, but possibly save billions of dollars every year. So I, for one, would think that we should have the proper study and fund it properly. So anyway, but we'll decide that, I guess, later. But thank you very, very much for the update, and appreciate your contribution, and we'll probably seek your advice again in the new year soon.
Thank you.
Thank you. We're going to adjourn for just a few moments, then we're going to go into committee committee business in camera. Thank you.